Hello and welcome to another insightful episode of Synapse NG with Dr. Akimbo Olaotitoji. This is the space where we bridge the gap between complex scientific research and everyday health outcomes. Today, we are diving into a topic that sits at the intersection of molecular biology and women's health, cervical cancer, and the human papilloma virus, HPV. Despite being preventable and treatable, cervical cancer remains a significant health challenge in Nigeria. However, the fight is being led by brilliant minds using biotechnology and genomics to change the narrative. Today, we explore the science behind the virus, the latest in diagnostic research, and what the future holds for prevention. Joining us today is a powerhouse in the field of medical microbiology. She's an assistant director of research at the National Biotechnology Research and Development Agency, NABDA, in Abuja. With a PhD in medical microbiology, she specializes in molecular diagnostics and bioinformatics, leading the biomedical informatics and biomolecular simulation unit at NABDA. Beyond the lab, she is a dedicated advocate for women's empowerment through Optimist International. She is happily married and blessed with children. Please welcome the brilliant Dr. Priscilla Aondona. It's an honor to have you on Synapse NG.
So much, Doctor, for that wonderful introduction, and thank you for having me. Good day, viewers.
All right, you're welcome. Let's start with the why. With such a vast background in microbiology, I want to know what exactly drew you to the study of human papillomavirus and women's health.
Why HPV? Well, I would say based on personal experiences, I actually had one or two close relatives that died from cervical cancer, and I was in school back then, and I was inquisitive, started asking questions. Why this? As we all know, the wealth of a nation lies basically on the woman, the health of the woman. Once a woman is down, the home is disorganized. So there was a lot that got me thinking, and as a microbiologist, I studied microbiology, and I felt, okay, why not go into more medical microbiology, see the impact you can make on women. And I was inquisitive. It was just the curiosity of what causes cervical cancer, how do people get it.
Now, let's go to the fundamentals. The link. For our general audience, could you explain the specific relationship between HPV and the development of cervical cancer? Is HPV infection an absolute guarantee of a cancer diagnosis?
Okay. Relationship between HPV and cervical cancer. First of all, what is HPV? HPV is an acronym that stands for Human Papilloma Virus. Human papilloma virus, as we've said, the name is a virus that is sexually transmitted, a double-stranded DNA virus, and it is sexually transmitted. It affects basically women because it establishes its infection in the cervix of a woman. That is where, when infection occurs, it proliferates. HPV establishment or infection could lead to cervical cancer. So you having an infection does not mean you'll get cancer, but most times factors come in based on the type of HPV you're infected with, and then other factors, environmental or health factors, would also make the virus persist and lead into cervical cancer. Cervical cancer could only develop when there is persistence of high-risk infection, high-risk type infection. If you're infected with the low-risk type, there's no cause for alarm, but that does not mean you would not be going for regular routine screening, because in a woman's system, over 80% of sexually active women acquire HPV at one point or the other.
Thank you for your response. Thank you. Great. So now let's look at the research. The work involves molecular diagnostics and genomics. What have your recent findings revealed about the specific strains of human papillomavirus that are most prevalent among women in Nigeria?
Okay, thank you for that. Recent findings. Okay, my research work was actually on prevalence of HPV in Abuja, women attending specific hospitals in the Federal Capital Territory, and my sampling technique was based on the 6 municipal council areas. The prevalence rate was around 10.9%, which was actually a little high. After even statistical analysis, risk factors like smoking, age, HIV status, long use of oral contraceptive, yes. Parity, that's the number of children one has given birth to, number of births that have passed through the birth canal, number of sexual partners. Those were risk factors that were considered in my research work. And even after statistical analysis, there was a significant association with those risk factors and HPV infection. And molecular diagnostic measures were done using PCR technique, and about 9 types were isolated. 9 types of HPV were isolated, which included a good number. Out of these 9, just about 4 of them were low risk type. The other 5 were high risk type. So what does that tell you? And the common type, which is high risk type, which is type 16 and 18, which is very prominent even in our local population, was also isolated.
Doc, let's move on to diagnostics and technology. Talking about bioinformatics in health, you currently lead a unit focused on biomolecular simulation. I want to know, how does in silico, that is computer-based research, help us understand cervical cancer better than traditional lab methods alone?
What I would say is what we call in silico research, that's computer-based research, not wet lab, are quite different from wet lab research or clinical research, but in silico research would not and does not replace clinical research. When you use in silico method in carrying out HPV research, you're just trying to collect vast biological data, generate hypotheses, and then guide the experiment to be more efficient. Application of bioinformatics or computational biology or mathematical modeling or artificial intelligence only helps in you understanding either the HPV and host molecular interaction. These are, you use models to see how HPV oncogenes interact with host proteins. It aids research, but it's not eliminating clinical research, because when you do a computer base, you have to practicalize it using the wet lab. And in silico research has helped in the sense that it also identifies new molecular pathways that would disrupt or interrupt during cervical cancer development. It also, in silico research has helped in HPV research based on the fact that it helps in predicting disease progression based on probably, if you know the HPV genotype, the viral load, and then the host gene expression. Also in drug target discovery. This is a disease. So in day-to-day research is being carried out to see how drugs are being developed. And this can be done using virtual screening of compounds. When you develop a library of compounds and then you do a virtual screening against the HPV-related targets and all that. Also, molecular docking can be done to predict drug and protein binding. That's the drug target you're using against the HPV. The HPV in question is what I'm calling the protein. So in silico research has not eliminated lab or clinical research, but has rather aided in the sense that whatsoever computational tools you use on your system to either predict drug or develop drug targets, it still needs to go into the wet lab for clinical trials before it is being sent into the population for use.
Okay, let's move on to early detection. What are the current gaps in cervical cancer screening in Nigeria? And how can molecular diagnostics make screening more accessible or accurate?
There's a lot of gap. Yes, I would say that. First of all, you're looking at there's a low screening coverage because of lack of organized program. How often do government or even non-governmental organization organize program to give an awareness on what cervical cancer is? Based on research that have been carried out, you have day-to-day publications being done in HPV or cervical cancer development in Nigeria. With this data that is being generated, how often do NGOs or government organizations create awareness to make the population know that this infection is rising? If something is not done about it, in 5 years to come, what will be the health status of women in this country? There's a low screening coverage. How many hospitals even do pap smear? In just Abuja, as we're talking in the FCT, the Federal Capital Territory, how many hospitals? So there's a lot, and then you have limited access to an infrastructure. You have limited access because a woman in the rural area would have to come to a tertiary hospital in an urban area or a private clinic. So leaving those areas, because primary healthcare facilities don't have those infrastructures to screen. They lack equipment, they lack trained personnel. So how feasible is it? So, and then another thing is the knowledge. Are people even knowledgeable about what HPV is or the persistent infection leading to cervical cancer? A lot of people don't have that knowledge. Social cultural beliefs, fear of screening procedure or misconception that cancer. Like during my research work, I came in contact with women in the rural areas that had sociocultural beliefs like, no, I cannot open my private parts for you to see and collect anything. That's the way they see collect anything. A woman is more at peace with, okay, you're collecting blood sample, here is my hand, than she opening up to you. Some of them, they are not, their cultural beliefs. Oh, like I don't want to be opened up. And some of them, when they see the tools like the speculum we use to open the cervix up before collecting your sample or even doing a VIA, the fear, the social cultural values, these are gaps that need to be closed up. Then you talk about financial logistic barriers. When you're talking about logistic barrier, you look at a woman, give example, okay, pap smear is 4,000 or 5,000 thereabout. Then the distance, the transportation she will take to an urban area, coupled with how much she will pay for. And then you see these are challenges that government need to look into to close the gap. The financial constraints, screening is expensive. Cervical cancer screening is expensive. VIA has been scrapped out based on its false results. This is visually inspected by the personnel, and most times you have situation of false results and all that misconception. So pap smear for now, it's even the primary form of screening. But is it accessible? Has government made it free for a rural woman or a civil servant to have access to it? Then you're coming into the molecular aspect of diagnosis, which is the DNA typing, to know the type you've been infected with. And so with that, you see the financial constraint. Then you have the health system constraint. You have shortage of staff and supplies, consumables, even to stain pap smear. You go to government hospitals, sometimes they start routine screening, and after a while, they can't keep up with buying consumables. So you have shortage of trained staff. To be sincere, through my course of even sampling or collecting samples, I was actually trained on that, on collecting samples. And at a point, I don't mean to be demeaning, but I was attached to a gynecologist. And when I went there with the gynecologist, the hospital's policy was they wouldn't allow me to collect it based on I was the researcher. So they are gynecologists. And when I went there, the gynecologist said, Madam, how do you collect it? I had to still collect it and show her. So there's no training, short of trained staff and all that, no follow-ups, follow-up processes. So these are the gaps that are just widening when you look at cervical cancer screening. These are the gaps and the challenges we are facing. And when you look at how can molecular diagnostics make screening more accurate? Yes, molecular diagnostics is the most accurate for now. Basically, my research, I used PCR, which detected high risk type and even low risk type. But you also have advanced techniques like the next generation sequencing, which even captures broader. If a PCR can detect just 15 types, next generation sequencing can detect up to 25, 30 types, which are advanced and advanced method of diagnosis. Also, molecular testing has given room to high sensitivity for it detects the DNA that pap smear cannot detect, or VIA. It identifies women at risk of cervical cancer at the early stage. Because once you know the type and you know I am infected with high risk type, the follow-up would make you and everything would be better off. Molecular testing has exposed us to having standardized results. Is genotype specific, reducing unnecessary follow-up like the pap smear or any other technique. So molecular diagnostic has made cervical cancer screening accurate and also accessible. We have techniques now that there is self-sampling. You have rapid diagnostic kits that a patient or a woman can take the sample herself, run it on the kit, and see the results through just like the pregnancy test strip. So it has decentralized testing, giving faster results. You don't have to go to hospitals. Advanced countries now do self sampling, collect the sample and test it and send it for testing. And this is what molecular diagnosis has exposed screening, cervical cancer screening to. And other techniques are still coming out. That's reduced molecular diagnostic technique has also reduced the frequency of screening, because when normally you do a pap smear, routine pap smear between 2 years to 5 years, you have to go back. But when you do molecular diagnostic testing, which has high sensitivity, and you know that your result is negative over a period of 5 to even 10 years, so before you go for another routine check, especially when you know you don't have a high risk type, and this will reduce clinical hospital visitations and all that. So molecular technique of screening HPV has really, really gone a long way and has helped in reducing burden in screening processes.
Thank you for your input, Dr. Priscilla. Now, Doc, let's look at prevention and vaccines. We're talking about vaccine efficacy. There is often public hesitation in HPV vaccine. Based on your research into microbial genomics, how effective is the current vaccine against the strains we see locally?
Yes, the vaccine we use now is the Gardasil 9, and Gardasil 9 covers up to nine HPV types. about two low risk type, which is type 6 and 11, which causes warts, and then the high risk type, which is type 16 and 18, the most common one locally found in our population. Also type 31, 33, type 45, 52, and type 58. So the vaccine presently available in our local population is the Gardasil 9, or how accessible. It is used in Nigeria's national vaccination programs to prevent cervical cancer. If there's a high coverage of this vaccination, it will reduce drastically the incidence of HPV infection rate or cervical cancer.
For that. Now, let's look at the treatment targets. The profile mentions computational drug discovery. Are we close to seeing new targeted therapies for those already living with HPV-related malignancies? Are we?
Yes, we are close to seeing new targeted therapies for those with HPV-related malignancies. We have drugs that have been developed over a period of time against HPV, and I know there are still drugs that are developed that are in early clinical trials that covers a lot of the high risk types that are common within the population. So yes, we are seeing new targeted therapies, and that's why as a bioinformatics specialist or computational biologist, most of in silico research is being done so that most of these new drug targets, when developed, could just be trials could be done in a wet lab to see how they would eliminate the virus in question totally.
All right. As a woman, I know that you will love this question. As a member of Soroptimist International, how do you think socio-economic empowerment for women impacts their health-seeking behavior regarding reproductive cancers?
A member of Soroptimist International. Soroptimist is an international organization that educates, enables, and empower the female or a woman. We are more specifically with the female child or women, work with women. And so when you talk about socioeconomic empowerment, how does it impact health-seeking behavior regarding reproductive cancer? Well, empowerment influences whether, when, or how women access screening, diagnostic, preventive, or treatment and services. And you could empower women either financially. When a woman is financially empowered and she could stand on her own, health is her priority. She would always go for screening. And educational empowerment is another thing. A woman who is educationally enlightened, like even in the course of my research, women hospital facilities that were in the urban area, I didn't have challenge explaining myself. When a woman knows that, oh, you're doing HPV DNA typing and this is free, I'm not paying it. I had a client who came and had to refer like almost close to 10, 15 women that this is going on free here. This is going on free here. It was a research. It wasn't a national or a sponsored program. So if not, awareness would even have been created in urban cities to get more participants. So educational empowerment is key. When you look at the rural women, the conception they have about a woman will tell you, no, there's no need. When you open up, if you open me up, you'll see something there. So leave it as it is. So educational empowerment goes a long way. And also empowerment structures like decision-making autonomy, a woman having the right to make her own decision and know that at this point, I need to take care of my health, go for routine checkup and all that. Then also the social and psychological empowerment comes in because someone who is psychologically or mentally stable would know that his or her health is a priority. Her health is a priority. And then women forming social group to encourage one another. Like for me, anywhere I find myself among women, I'm always talking about cervical cancer. Cervical cancer, they've never been an epidemic, but the incident rate is increasing. And the persistent rate is also increasing because of lifestyle and other environmental factors women are exposed to. So wherever I find social groups, I make sure I enlighten and educate women. Also, employment and social protection. When a woman is employed, even by the government, employment will give her room to health insurance. With that, it has gone a long way. And when a woman has health insurance scheme, she wouldn't be saying, "Oh, I don't have money to go to the hospital or there and there." So, empowerment goes a long way in helping women regarding any cancer or reproductive cancer at all, whether financial empowerment, educational empowerment, then employment and psychological empowerment and all that. So it does go a long way in making the woman have a decision about her health.
And let me take my last question, Doc. It's been such a wonderful time having you on the show today. And looking at the future outlook, if there is one myth about HPV or cervical cancer that you could debunk for every Nigerian woman listening today, what would it be?
If there's one myth about HPV or cervical cancer that I would debunk, it would be cervical cancer is a death sentence. No. Or is a spiritual attack. No, that's not. Or once your HPV is you get infection, you must develop to cancer. No, that is not true. HPV infection lead to cervical cancer if it persists, if you're infected with a high risk type. But most time we advise that preventive measures be carried out. If you know that as a woman at any point in time you are infected, once you're sexually exposed, at any point in time you have an infection, then go for routine screening. No one is telling you about going weekly or monthly. When you go for a routine screening, the first time over a period of 2 years, you're asked to come back when it's negative. Even for a pap smear, when it's negative, they tell you over a period of 2 years. But when you go for more advanced technique like HPV, molecular diagnostic, use HPV, diagnosing the HPV DNA or typing it, when you know the type, it gives you more assurance and even more time to come back for a follow-up, which is between from 5 years. They will tell you after 5 years, come back and check again. These are things that nobody's requiring your everyday presence in the hospital, like you're going for a malaria test or a typhoid test. No, these things are things we could preventive measures that could be taken. And then if you know you have not been exposed to any sexual contact at all, go for a vaccination so that even when at any point you are exposed, you are being protected by the vaccine. This is very easy. I tell women, if you care so much about the well-being of children, even if you don't have children, your family members around you, you will take care of yourself. And so that is what I'll leave this wonderful session with. HPV infection is not a death sentence. Cervical cancer is not a death sentence. Early detection and screening. I've seen people who have done hysterectomy and are living for over 10 years now. They didn't come down with cervical cancer. I've seen people who have undergone cryotherapy and followed up with antibiotics and everything is fine. So cervical cancer is not a death sentence. Early detection save life.
Wow, what an enlightening session we've had today. Dr. Priscilla Aondona, you have reminded us that while the science behind HPV is complex, the goal is simple: saving lives through early detection and informed decisions. Thank you for sharing your expertise with us today.
Thank you very much for having me. I hope this was an educative session. Thank you.
To our audience, thank you for tuning into Synapse NG. Knowledge is the first step toward health. Don't forget to share this episode. It could be the nudge someone needs to get screened. I am Dr. Akimbobola Otitoju, and we will see you in the next episode. Bye for now.